Hi again. Thank you for doing this with me. So I'm just going to remind for anybody who's going to be watching this that you are Dalila, an awesome midwife who's like legendary already here in Tbilisi. Because whenever
you're the only one, I think.
Yeah, the only one. Yeah, real midwife. But honestly, even among the midwives who are here, obviously it's like even out of the question that your professionalism and your expertise and your knowledge is just like so valuable, and it's a blessing that you have been here for the time that you were here, and I hope to see you soon, really. And
Yes,
also it's very special to me that remember when we met, it was just like such a coincidence because you were from Northern California and well, basically from San Francisco, where I gave birth to my son, and where I kind of got in touch with the labor and delivery theme and the system, and I was like learning a lot about childbirth through the prism of what's usual, what's typical, what's habitual in California. And now we're here, like, together collaborating in Tbilisi in Georgia, and now you're back in California. So, like, I mean, I love how the world is just like putting us in such situations and makes these twists.
Definitely a fortuitous meeting. Very
Yes.
unexpected.
Like the Dr. Zaza at that time told me, he's like, the stars aligned because you were from California, I'm kind of from California in that way, and he was flying to California, to San Francisco all the time to UCSF to do some training or whatever he was doing there. So it was awesome.
The fellowship at UCSF for a while. So and the inspiration for his birth center really came from his time in California. So that was just like you said, stars aligning.
True. So I really wanted to talk to you about, in your experience, what really changed with COVID, with all of this that happened. I feel like there's such a lack of conversation around this, about the amount of impact that has really taken place on the pregnant women, on women who are in birth, in childbirth, on women who have delivered and are, new moms with very limited access to support in the postpartum period. I mean, such a grand topic. Well, since you're a labor and delivery midwife, like maybe you could tell a few words about like what in your experience has really changed for the mothers who are in labor in your unit, and for the staff, for your personnel.
Yeah. A lot has changed. I think in general, I feel like we're all in survival mode with COVID. One, because there's just so much unknown around it. And that is just even more so amplified for women giving birth, because already just in the most normal times, having a baby anywhere in the world, I think is just kind of encountering the unknowns over and over for women, even in the best of circumstances. So now we have this kind of situation that is so uncertain in so many ways for people, and it's constantly an evolving kind of in real time situation. And being in survival mode essentially is it's hard to focus on quality of life when you're in trying to survive, right? In any aspect. And I think so a lot of things to focus on as healthcare providers, as birth workers, is quality of care, right? We want to always bring to the forefront that women deserve in every setting to be valued, to be seen. That's even more problematic now with COVID, because when you're in survival mode, all of those things, it's like the Maslow's kind of hierarchy of needs, right? It's very difficult when you're just trying to kind of get by, wrap your head around kind of just like this ever-changing situation, to really focus on equality and making sure women are seen and making sure women are forgotten. So it's even more problematic. So that's just kind of to set, kind of create a set for this. More specifically, everything's changed. I mean, from the way, so let's first take healthcare providers. Guidelines are constantly being changed and evolving, in some ways for the better. An example would be, at the beginning when we were all just like, what is this? How is this going to affect women? How is this going to, everything from who can attend a birth to how are we going to support women in breastfeeding has evolved. We're now at a place where we allow women and actually encourage women to have not just one family member, but also a birth worker with them, because we consider that a professional. So they can actually have two people with them, which is amazing. That's a change. Whereas at the beginning, it was like, we don't know. We really just want to just close it all down until we figure it out. We're now not separating women, even women who are tested COVID positive, from their babies. We're encouraging breastfeeding for women, even that are COVID. So a lot we have relaxed a little bit now that information. But as providers, it's different. Being a midwife, therapeutic touches everything. Like, we are in there actively providing care. Being close to women is kind of a huge part of our profession. And now there's just physical barriers to that, right? I mean, I have an N95 mask, which I can barely breathe through. I have a shield. I have, it's kind of like a hazmat suit that I have on, more or less. I mean, that's a physical barrier that makes it so hard to provide the care that I want to provide. So that's just the physical barriers of it. Having to don all those things every time you're attending a birth or you're doing an exam. It limits the amount of times you walk into the room. You're trying to already think, whereas before I'd freely walk into the room more often. It's just like basic limitations to your care. You begin to feel like you can't be present as much as you would otherwise want to. For women, I mean, like I said, it's just compounds an already kind of a very difficult transition, a very unknown experience now with even more kind of complications. In our practice, we used to allow a woman to have as many people as they want in the room. Like if she wanted to have her whole family there, she could. Now, of course, we have limitations on the number of people that we can only have one person, one family member with you. If you'd like a doula, that is also an option. So up to 2 people. So that's, there's real limitations to how we provide.
Is it a family member particularly? Do you check if it's a family member, or it can be just like a best friend or anybody of her choice? Anybody.
Any one person. And we generally try to inquire about that early on, and we kind of in our system have a little note. So when I admit them, we already know exactly who their support person is. Of course, they can change their mind. We're just, as long as it's one person and they can come and go, but they can't switch out. So you can't tag somebody else in. For instance, it's your husband, partner, and then it's your mom. We try not to allow that. And then if you have a healthcare professional, and doulas we consider healthcare professionals, then that's a second person. It wouldn't be in place of your support person.
Yeah, this is amazing, girl. You're telling me just like, I don't know, a dream come true for like the Russian, for example, healthcare system, which is like, we would dream about it in a regular time, in the peaceful times. It's still something we were not able to like easily implement. To depend so much on the hospital and who thinks what. And oh Jesus, like my heart is bleeding when you're telling me these.
I left Tbilisi at the end of March, so I've been here really for the majority of the COVID kind of evolution of COVID. When I left Tbilisi, it was no one could. I think they actually, some places started allowing to have one support person. Has has that changed?
In the peak of the restrictions of the quarantine, all hospitals were shut down except Pineo. They were allowing one partner in. So we actually had labors and with the husband, and then at some point I was also allowed to come in. So we actually, like, the family had, like, the woman had the husband, myself, and also an invited doctor who was, like, on the contract with them. So we were, like, rushing to the hospital before the hour, the curfew, and then we spent the night in the hospital, and then we would leave and then come back again. So in all other hospitals, everything was closed off. Nobody, not even a family member, was able to come in. And at the same time that the epidemiological situation in Georgia has been assessed as very good, very peaceful, and very calm in comparison to the majority of other countries. And up till today, as far as I'm concerned, there has not been a case of a laboring woman with COVID plus.
Well, they're also, I'm assuming they're not testing. So we are testing everybody that's admitted.
Oh, I see.
With their consent. Obviously, we can't force any test, but we offer a test to every woman who is admitted, and we do 2 tests. One is a rapid test, and the results come back within an hour, and one is standard test, and the results come back the next day. And the benefit of doing both is, one, you get immediately results back. It's not as reliable. There's a little bit more false negatives with that one. So we always follow up with the standard, which is more reliable. Again, of course, we make sure that we provide all the information about the test. There are women who decline it. They say, no, we don't want it. But majority of women do accept the test.
So it's not mandatory. You're not, like, rejecting the woman because she's not willing to take the test.
I mean, not everything has to be done with informed consent. We can't force anything on a woman. Everything that I always tell women, from the moment you step into the hospital, everything that is done has to be done with your consent. If you can leave, you're not held at all. You're not forced to do anything at all. My job is to tell you, and I tell women honestly, I say, this is the reason why we offer these tests is because it helps us to know how to care for you better, and it helps us to protect ourselves better. So, for instance, if you do test positive, then we will put you in a negative pressure room, which is safer for you, for your family member.
What does it mean, a negative pressure room? Can you tell more about that?
It's a room that's designed, each unit has a couple of rooms for airborne precautions, meaning any airborne disease that a person has, right? In this case, it's COVID. And it helps to just suck the air actively out of the room, right? So it just helps to clean the air a little bit. So not all rooms are equipped with negative pressure because it's obviously a different ventilation system. And so we have rooms that are designated, 2 rooms as negative pressure rooms. So if we know you're positive, then we can take those precautions and put you into that room. We'll know to.
Yeah, I was just like, the first time I'm hearing about this, and what other cases would be what other diagnoses or conditions would be placed in such a room?
You have active tuberculosis. It's very rare that we would have anybody that would need that. But if something else is going around, you have a really bad
anything
case
related to respiratory or infection, anything like this?
This is not just. I mean, I think this is just standard for every hospital. Every unit has to have rooms that are negative pressure rooms. Also,
and this is how you go about it, right? I'm just thinking that since, and it is a question, like a much bigger question towards the system, how it is prepared for outstanding situations like this. The majority of the world is facing something like this, and they're like, oh, sorry, the only option we have is to shut down and deny women in their human rights of support and everything that comes with it, because we as a system are not prepared, because our hospitals are old, because we don't have anything like any negative. What? Like, to me, from coming from a post-Soviet culture, this is like cosmos, you know.
Yeah. Yeah.
And you guys are prepared, and California has always been like in the front line of implementing guidelines, and really, you know, the guideline comes out and you guys use it actually, and this is like fascinating to me. And you're trying to keep up with any changes, whereas the rest of, like, okay, not the rest of the world, it's not fair to say this, um, but at least the countries that I know, like Russia and Georgia, for now, and I'm assuming like the post-Soviet, Armenia,
Mm-hmm.
a great example also, um, they heard the first restrictions, and this is where they stand still several months from that time. And you're saying the guidelines are constantly changing. You got to be flexible. You have to, you know, adjust all the time.
Be able to adjust. I mean, I think so. There's a lot of things going on here. One is, in general, United States isn't doing well with COVID, nowhere
Mm-hmm.
near as Georgia is doing. So I'll put that out there now. I'm not
Yeah.
speaking as a person who's like, oh, look, we are. It's a
The
whole different.
numbers are
It's a
bad.
whole different conversation about all the ways in which we have failed federally, and that's a whole, like I said, that's, I could talk about that for hours. But so there's a few things going on. One is, again, the United States is large, and California is large enough to be its own country, really.
And
And so
labor and delivery is very different
very
across the states.
across
True.
the states. You could have, absolutely. It's, I mean, really, United States is like operates like, I mean, you cross that state lines, it's like you're traveling to a different country, you know.
Sure.
Each state really operates independently in many ways. There,
Mhm.
so depending on where you find yourself, you'll feel like you'll have culture shock traveling just from state to state. So I definitely don't want to speak for the whole country, and I definitely don't want to make it seem like we're an example to follow especially when it comes to COVID, because I think I always proudly say, every time I'm in the hospital, I'm like, God, you know, the place where I live, which is Georgia, has this thing under control much more than we do. And it's a fact that's a fact. That's partly due to, you know, Georgia's early lockdown and early response and closing the borders. And again, that's much easier to do when you have, you
Well, it's
know,
a tiny country.
and
Yeah.
these, yeah, and more or less people are, you know, homogenous and kind of are on board with. You don't. The U.S. is very difficult. It's like herding, you know, a million cows. It's just a very difficult thing to do. So I do want to put that
Yeah,
out there.
I hear you.
In
This, yeah.
am I saying that our response to COVID as a nation, or even as a state, I mean, the state is large, has been, you know, like, this is what an example to follow. So there's a lot of things to fix and a lot of things to do. But I think the prioritization of women as a culture, right? For instance, even amidst like a pandemic, to say, wait a second, to have voices that say, wait a second, we still have to uplift women. We still have to support women. We can't forsake women in this experience that they're having. Same thing with end of life care, for instance. That has come up. What about hospital units
Right.
who are at the end of life?
Hospices and
They
all of that. Yeah.
alone. No, they don't. So there's certain risk that, yes, of course, locking everything down and creating sterile environment is a good way to keep numbers down. It's an effective way, but at what cost, right? At what cost of quality of life and care? And how are we traumatizing people who are not able to say goodbye to their loved ones at the end of their life? Or pediatric units where children have to be left alone and not have support, or labor and delivery units where women absolutely need support,
Yeah.
absolutely need support from their loved ones in order to have an experience that is not traumatizing to them. So
Exactly. This is the
you
word that I wanted to say just right now. Like how the I am a psychologist as well, so like I can't not look at also like the current and upcoming effects of the level of trauma that we're again going to have, and you know, after this wave of the pandemic is gone, and then we're going to deal with the results of women not having access to support, and if in California, again, not idealizing, but I gave birth in San Francisco. I lived in the States. I know that what is kind of typical and normal, and what is kind of typical and normal in terms of communication between the staff and the laboring woman. And we all know, we got to be honest, that in the post-Sally countries, the level of obstetric violence and aggression is much higher, and verbal violence, and just treating the woman as a piece of meat, and very a passive,
Absolutely normalized. Yeah.
passive, someone passive who doesn't really matter in the process, who's just laying flat the entire time, and this is how it should be, right? So, I mean, the that's traumatizing enough, and on top of the limitations that are put like layered on top of this, like not even having the opportunity to take a person who you care about with you in the room, even though it's your husband who is absolutely not familiar with the process and it's relatively new for the culture, it's still better to have him there rather not to have him there.
Absolutely. And it again goes back to this theme of survival, right? And the idea that when everybody is trying to survive, that thriving isn't important, that it's those ideas are somehow mutually exclusive, right? That if we're trying to survive, nothing else matters. All we care about is delivering your baby and making sure that, sorry, is that my phone that's making noise? I apologize. Delivering your baby and making sure that we have a live mom and a live baby. And I mean, that's not the goal when it comes to good care. That shouldn't be the goal. That should be the bare minimum, to make sure that you're alive and your baby is alive. Really, we should be the stars when we provide care for women. And we can't, the idea that we can't do both is we can't do both, that we can't provide good quality care, but also ensure that you're not traumatized in the process. So those concepts are absolutely not mutually exclusive. So it's on a little bit more risk when we allow a partner and a well, sure, yes, potentially there's an extra person that can potentially spread the virus, but we can mitigate that risk, right? And at the same time, for us, it's greater than the risk. So it's never going to be about eliminating risk fully. You can't with the virus. You have to kind of find a place that you can live with, right? A medium that you can live with.
A balance.
A balance for us is we'll do our best. We're not going to allow you to have 10 people as you previously would have wanted to. We are going to create limitations. We have to. Limitations are part of kind of navigating this virus, and coming out on, kind of surviving this. But we also have to consider what is important. So we have to survive, but we also have to thrive. And we can't, but that's the most important thing. I think that some of the countries that you name, like post-Soviet countries, it's very easy for them to go back to their default of that is non-essential. Those things are not essential. Doula care is not essential. Supporting women and making sure they don't have a traumatic birth is not essential.
Not essential. It's like
cultural and
if you want to play with that, we will allow you to, but
yeah,
it was actually something we were explicitly told, and what kind of sobered me up a little bit. To answer your question, what happened after you left? So for roughly 2 months, all of the hospitals were on strict closure, and then this limitation was taken off, and I was under the impression that it was taken off everywhere, since the guiding or like the leading hospitals in Tbilisi allowed partners in. Doctors are not wearing the ammunition anymore. Nobody's wearing N95 masks, so that you know. And that's actually something maybe you would want to comment as a medical professional on. I was under the impression that everybody has it, but no. And I was invited for a birth in Batumi, and the mother who hired me, she was denied the opportunity to invite me, because they had never heard what is a doula. They had never heard of what is actually support in labor. So it turned out to be like in one of the leading hospitals, but they were like way back in some of their notions and understandings. And only one hospital, like the leading hospitals, denied them access of her husband even. They literally, the quote that they told her, like, you don't need him, we're going to give you much better support, like, don't worry about it, we'll take care of you, you know. And obviously not even like a third person, which is me. And then the other hospital, which is like a very old school hospital, they allowed the husband in, but to the word doula, they're like, no, it's our responsibility. Well, everything that you usually get from people who are not familiar with what it is. And so, yeah, she said she had it all, you know, in terms of the limitations and the closed doors. And I saw this building, and it's very like 100 years old building with like, I don't know when the last renovation was done. And they're really pushing onto this myth that, you know, it's quarantine everywhere. We're protecting you, even though, in fact, no protective gear, open doors between rooms, and all of this, you know. So I really don't see personally a change in the behavior of the staff inside the hospital. And in my understanding, if you put the limitations in, I'm happy to follow them, but I need some understanding, you know, and the mothers need understanding. I hear a lot of surprise, like from women, like, okay, what is the worth of me not having my partner in when the only thing I'm getting is just closed doors, and inside nothing seems to be responding to the idea that there is a pandemic happening. Do you know what I mean?
Yeah. I
How do
mean,
you
I
go
think
about that?
for a lot of people, they're using the pandemic to just exercise their bias against doulas and extra support people. It's like I said, it's all, if anybody who really understands or has studied, and there's no shortage of evidence in support of doula support in labor. I
Sure.
mean, there's really
Just
isn't there.
open Google.
There is not one study that disproves it. I mean, it's really just 100% of the studies ever done show that support in labor helps outcomes, you know, or preparedness prior to labor and support in labor. So, I mean, really, this, like I said, this is a cultural shift that has to take place, right? So, if you already don't know about doulas, so you're either coming from just truly just willful ignorance, kind of, you just don't know, and it's something foreign, and you don't want it. You're like, what is that? Or you know, and you just are like, what I find in people in that part of the world take it very personally. This is my job. That's what we do for you. Who are you to
Yeah.
step into that? When in fact there is actually no competition at all. Like it's like apples and oranges, and we like both. And I don't like to choose between apples and oranges. So it's a misunderstanding of the roles, and it's partly because it's not culturally certain. Like, how are they supposed to know if it's really nowhere, nobody talks about it? It's a completely new and novel concept. So partly it's just you're already primed against these things, and now this pandemic comes that gives you the right to say, no, we're closing doors to everybody for safety reasons. Now that wave may have already passed, and we know for Georgia it has, but people who have a
But
bias.
still, the restrictions are in place. I was shocked to learn that even as of today, August 7th, some of the hospitals in Tbilisi are still not allowing husbands in, partners in, relatives for the birth. Nobody is allowing in the postpartum unit, like visitors in the postpartum unit are prohibited in the majority of places. And outside of Tbilisi,
I mean, I think it's
it's
actually
been like
quite
this all the time.
litmus test for Georgia, because all the progress that has been, all the accomplishments that they've made in the field of like allowing women to have autonomy and acknowledging women's need to support women in labor and not to cause trauma. And I've seen like evidence in certain hospitals of people being completely on board with that. I think this is an interesting test of do you fall back into old patterns because it's easy, or are you through this difficult time still going to advocate for women in the way that they deserve to be advocated for? Again, we can't abandon our values just because things are hard. And so if you try and if you abandon your values when things are hard, then were they really your values? And I think that's kind of ultimately the interesting test for Georgia is if we fall back into our old Soviet pattern of this paternalistic medical healthcare system, then did we ever change? Did we ever move away from that? And my answer is no, we didn't. If that's what you so easily fall back into. What happened to all of the women's rights advocacy that was happening in Georgia already when it comes to healthcare? Where did all of that go? And if it disappeared so easily, then was there any real and true change that ever took place? So this is very interesting, right? So
it is interesting not hearing like any, like in the women of New York, we all know the story, right? When they were just limited access and then all of a sudden they're like, what? No, this is not happening. And in 3 days, the mayor changed it all back and partners were allowed back in. And obviously, I don't know the language. I can't speak about everything. Maybe there are women who are like protesting against it or not, or saying that something is not okay with this. But I'm guessing that the majority is like, okay, well, it's for the good, and then this is for the good.
When this whole thing happened, like I said, when it was so uncertain, when it was so difficult, I think if we can forgive the drastic measures that were taken, because I think,
nobody knew what was going on, and everybody was trying to like,
you sometimes
take the precautions they were able to take. That's understandable.
Yeah. But I think that once you're out of the state of emergency, it's important to again reevaluate things. And if you're
exactly
things, and if you're not, again, it's about what values you have and are you upholding those values. And if you're not, then again, you probably never truly were. Is my like what So I think there's just a lot to still advocate for. There's still a lot of education, a lot of advocacy work that needs to be done around women's health everywhere
in the world.
California, even in the United States, I think really everywhere. I think we really forget how women have it hard and everywhere in this world. I don't think there's a place in this world where women don't have it hard and don't face these kinds of challenges in one way or another. So this isn't about one place having it figured out and preaching to the next place about how to do it at all. It's about figuring out what we do better and what we can learn from. Like I always say there's certain things that even in California we can learn from other countries that far less about how they treat women, and especially in the postpartum period. I always say we're the worst in the United States or one of the worst about how we in the postpartum period. Essentially, we're just kind of like, bye, you're out and your own, and you have
I had that. That was amazing. Like on day 4, they told me I was supposed to go to a pediatrician clinic, and nobody explained to me why. And I was like 4 days postpartum, literally. I was barely standing on my feet. I didn't have a car, and we were like very short on money. And I grabbed this like car seat with my son in it, and I really like carried it on the bus to the pediatric clinic. And the doctor didn't even see me. It was just a nurse who measured the weight of my son. They're like, "You're good, bye." I'm like, "What?" It's like, really? That was all the effort?
Because this is the thing. It's really, it's very important to have I think, a very honest perspective on everything. And I definitely am not of an opinion that, everything one place has it all figured out. That's not the case. I think there's a lot we can learn from each other. And that's what makes this work so interesting. What makes my work interesting is that I get to kind of do it in very drastically different places.
Yeah,
and have a chance to really
imagining that's so contrasting for you, like it's such a contrast experience.
It's very different, just so different. My work here and my work in California and in Tbilisi, it's very humbling to kind of see see women's experiences from in different settings and in different environments. And in some ways it's easier, I think, in Tbilisi, and in some ways I think it's easier in many ways in California. But again, it's like there's no one perfect system, and there's a lot we still have to do to improve women's health care everywhere.
Yeah, I totally agree with you on this. Just maybe a couple of last questions. I'm personally interested in, have you noticed, or is there any stats about like how the situation has changed for women of color and all of these like social rights in the States? Like, because we know that this has always been the case, like women of color have not been treated as good enough on a general scale as like women, white women. And how is this situation evaluated these days?
I mean, I think, again, COVID has emphasized all the things that have already been happening. So we all just see now that women of color are disproportionately affected by this pandemic, as they have been disproportionately affected by all the other metrics, in maternity. So this
How
is
do you
not,
mean, are the numbers higher of COVID among women of color?
Nationwide.
Really?
Women of color in general suffer more from have worse outcomes with COVID than and a lot of it has to do access to care, and a lot of it has to do with access to testing and being able to get proper care in a timely manner. And I think that's just a healthcare system, like a reflection of our healthcare system and racism that is very systemic in this country. So there's actually there's no question about it. It's been studied, it's been observed, so there's a lot of work that needs to be done around that and around creating equity for women and opportunity, and making sure that we're representing women. I think this is more true in some areas in the United States, of course, than other areas. I think it's particularly hits home for me because I work in a very Northern California, as you know, is an incredibly
diverse population. Yeah.
And especially where my hospital is located, we serve a very special and underserved population of like immigrants and people from a lower socioeconomic status. I personally relate very much to these people because I once was an immigrant in this country, and I can relate to what it's like to navigate a healthcare system with no English and to no ability to represent yourself, to advocate for yourself. So this population is very kind of close to my heart, and and they're definitely disproportionately affected by prior to COVID and now in COVID, these pandemic times. It's a challenge. It's a huge challenge. And now the bigger challenge is, because of COVID, understandably, we have even less resources. Right? We used to have outpatient breastfeeding clinics and hours where women could come in and we had centering, for instance. I don't know, it's probably not, doesn't happen in Georgia, but it's group prenatal care, which studies show really improves not just satisfaction in your birth, but really reduces preterm labor and other complications. We used to actively have centering groups. Of course, that has had to stop with COVID because it's non-essential visits, meaning essentially we try to see women when we absolutely need to and do telephone visits. Again, there's unavoidable gaps in care that this provides, limited resources, community resources that are now limited that used to offer support to women, moms. again, part of it is just things you can't control. These are just things you absolutely can't do during a pandemic.
Yeah.
Of course, it's compounded. And again, it disproportionately affects people who are underserved and who are poor and who don't speak English, right? You can understand that people who have status and money, they will always find a way to find support.
True.
More opportunities for people like that. And so of course, you can understand how during a pandemic, the problems that we had are just magnified even more.
Yeah.
So there are
That
definitely
also, yeah,
limitations.
absolutely. And that also makes me think of how our human connection is being tested on a grand scale. I recently listened to an interview of Robin Lynn. You probably know her, right? The Bumi Sehat, the founder of Bumi Sehat. You don't know her? She's a like the world known and like um, with many awards person who's she's American but a woman of color, and uh, she has created this amazing birthing center in Bali, a world
Oh,
famous center, Bumi Sehat, which is notorious for its natural approach and humane approach to childbirth, and they are serving um, poor and underserved population, which is a big chunk of the local population. And many women from all over the world go to their Bumi Sehat to give birth. Um, she's an amazing soul, and she was just saying in this conversation in this interview that she's a midwife herself, and she says we're very limited as midwives how we can interact with each other. We're not able to hug anymore, and this has been the custom in our clinic. And we would hug the woman that comes into our hospital or clinic. The first step she makes in, the first thing they're going to do is hug her. Even like all the staff will hug her and give her this like human approach. But she said that now we're just like hitting our elbows to greet each other, and she says we smile with our eyes. We still have our eyes wearing all of this gear and all of this. So they're really putting an effort of keeping and maintaining this connection of soul to soul, because like you're saying, the person under your care might not be an English speaker. You might not be able to find a common verbal language. And then what do you do? And I'm thinking about all of these healthcare providers who are out there and who are not able to even communicate in like verbally when they speak the same language. They don't know what is eye contact. They don't know what it's like to hug the patient, hug the laboring woman, or even the pregnant woman with your soul and just create this for her. And what do you do in this situation when you're not able to speak and use your words? You
we
need to
have
find other resources, right?
absolutely, you have to adapt. I mean, we have gloves on. We still, you can't, childbirth has never been a sterile process. And I mean, in any way, literally, it's never a sterile process. And, in any other way, it's impossible. When it comes time to have the baby, there's always some interaction you're having with the woman. There's always therapeutic touch, even if you have gloves on and everything else on. So it's impossible to attend a birth and not have that element. Again, that's been strained very much with this pandemic. We've had to limit ourselves and create more physical and other barriers. But you do your best. You try to spend time and you try to connect with the patient and the woman as much as you can, with the family as much as you can, and you have as many conversations as you can. It's just really, there's ways. I think we've managed to find ways to make women feel like they're still the center of their care. And ultimately, if that's your goal, you'll find ways to do that. And I think women understand that they're facing limitations and we're facing limitations. But I haven't been in a situation where I found that I can't provide good quality care and I can't make the woman feel like she is the center of her care because of the pandemic,
Because
right?
this is your value. I know you as a human, and this is
So
what you
want
bring out to the world. This is how you live. I mean, I wouldn't imagine a situation where you're not able to do that.
if it's your limitation, it's just an excuse. You should be able to still provide good quality care, women-centered care. Women should still leave after they've been interfacing with you, feeling good about themselves. This pandemic has nothing to do with. It cannot create that strong of a limitation. If your values again are in your hearts in that place, then you can do it. That hasn't been an issue. Is it harder to
I
do
love
it?
what you're saying. Yeah, this is so true. They're like golden words. So
So
the pandemic cannot limit your humanity, right?
no, it can't.
If anything, it can highlight it. It can bring it up to the surface and enhance it.
Try a little bit harder. Like speaking through masks. I mean, like we're all beginning to realize actually how much we communicate, not just like how much we do lip reading. Like we now realize that how much we hear by watching people talk. And now that we have masks on, we're always like, it's so hard to hear people.
Always
Because we're not seeing their lips move. So we're beginning to realize like, okay, we really just have to actually physically hear people. We have to speak louder. We have to enunciate. There's a million things we're doing differently. And they're all annoying. They're all annoying. Nobody likes it. Nobody likes wearing all this stuff. Nobody enjoys it. But again, there's no scenario where there's no workaround. You can always find a workaround all of these things. You can have longer conversations. You can have more reassuring conversations with the women that you're with. There's a lot of things we're relating on. Like, this sucks for you. It sucks for me. This is not ideally. I would not want to be doing it this way.
Let's find some common ground. Let's make it work as a team, even more so.
But what hasn't changed, I always tell a million things changed. Everything looks different. Everything feels a little bit different. But what hasn't changed is that you're here. You're in control of this experience. This is your experience. We're going to tell you everything that we're doing. We're going to discuss with you every step of the way. And we're going to just be honest with you. And you're going to know what's going to happen to you. And you can choose. You can tell me what you want. My job is to tell you. Again, these conversations, the way you speak to a woman can either make her feel good and strong, or it can break her completely. And that has nothing to do with this pandemic, and it has nothing to do with all the other difficulties that we're facing. It has to do with your approach to care. And that's pre-pandemic, post-pandemic, that'll be just constant. So if you don't have the right approach to care, all of these other things are not going to be deciding factors. They're just an extra things we're dealing with. It has not shaped our approach to care. In fact, our approach to care has shaped some of our guidelines, right? That's the reason why we have to be like, yes, it's bad, but we still have to have humanity in our care. We still have to give women what they need. We can't give them everything they want, but we have to give them what they absolutely need, right? So it's really about these conversations about finding this place that makes sense, where it's fair, where we're not just being punitive. We're not here just to punish you. We're not saying, we're here to really try to work with you, and you have to work. So
I'm so happy, honestly, for these women who are under your care. I mean, ever since I've known you, it's been such a resting place for the soul to communicate with you, even though like I'm not pregnant in the moment. And this is so like encouraging and so warming to just communicate with you. And I just wish for the world to have more midwives like you, and people who communicate with the women in this period.
That's definitely I really hope actually that midwives find their way to Georgia. I really think that.
Oh gosh, I wish for that too, man.
And again, just to reiterate, midwives do not replace doctors. We absolutely need doctors. We absolutely value doctors.
Yes.
And I work with doctors every day. I work in a hospital, and I rely on doctors, and they rely on our care. I mean, it's really such a symbiotic relationship.
It's a team.
Done correctly, It is an absolutely symbiotic relationship, and it's like two puzzle pieces, because what we do, doctors can't do. What doctors do, we absolutely cannot do. And it only, and that relationship only highlights the best in the doctors, highlights the best in the midwives, and offers the best to the woman and to the family. So I really, my wish is that will be true one day for not just Georgia, for like
all the post-Soviet countries where midwives have been just brought down to the function of putting a CTG monitor and protecting the perineum, basically.
Yeah.
Like that's a whole different conversation. Like probably
it's a lot of whole
week.
conversations.
Yeah. So maybe as like our wrap up, I would ask you to, as a specialist, as a medical professional who is out there in California, who is following the guidelines, can you tell a few guidelines or restrictions or limitations or precaution measures that are really justified, that are really important for laboring women to consider, and for the laboring women and for the staff, and the ones that are absolutely not necessary? They're just there for, to making it seem like there is a precaution, but they're not worth having and maintaining.
Yeah, again, I don't know what the status of, cases is in Georgia. I mean, a lot of this is relevant to what's going on here, right? And some cases have been, until really recently, on the rise in California.
Yeah. Well, in the worst case scenario, if there is like high numbers of COVID around.
Yes. So, okay, and generally speaking, again, like I said,
if
it looks like things are really well under control from what I know in Georgia. So I think a lot of the things I'm talking about won't even make sense. What we know for sure, okay, there's a lot of things we don't know for sure, and it's constantly evolving. But what we know for sure is masks work.
Mm-hmm.
You're pregnant and you're try to distance yourself as much as you can. Avoid unessential activities or crowd gathering. The density of a population, we know now, is like the number one factor in the spread of this virus. That's not mind blowing. It's very common sense. A lot of these are actually not mind blowing. They're very common sense things.
Mm-hmm.
So definitely err on the side of caution. And wear masks if you're around people. So that's the one thing we tell our women all the time. Make sure that you are avoiding gathering in places with a lot of people.
Does it matter what kind of a mask it is? Just so, like, I know it's also another whole conversation, but like, is it one-time disposable masks, or is it like cloth masks that you
whole conversation
wash?
About mask hygiene that we can have. You definitely don't want to be reusing the same mask and then just crumpling. So the idea is, when you put on the mask, the outside of your mask is always dirty, like always dirty. So you don't want to be flipping masks, your cloth masks. Don't do that. Make sure you always wear. The idea is, if you have several masks, rotate them out if you don't want to wash them.
If they're cloth masks.
They're cloth masks, you can wash them. If you don't want to wash them, hang them, and then have another mask you're wearing the next day. Hang it again, and then another mask on the third day, and then you can go back on the fourth day and wear the first mask, because really by that time, whatever that mask has not survived.
It's not suggestion
anymore. You can rotate masks if you don't want it, if you have several of them. You can wash masks, hang them to dry. The next morning you can wear it again if it's a cloth mask. Really, any mask can work for the purposes of just protecting really other people from you and from you kind of getting. There's no need to wear any kind of N95 masks or particular masks unless you're a healthcare provider, unless you're really dealing with people face to face in close contact, potentially people that are sick. And the other thing is that we've noticed with women that are pregnant is that they don't have really this, they don't get very sick with COVID. They're not, we're not sure exactly why. And kids don't either. They can have a very light version of this, but they do pass this on, right? So just because you are asymptomatic doesn't mean that you can't get other people sick. There's also a difference between being asymptomatic and pre-symptomatic. Asymptomatic meaning that you just don't have any symptoms at all. Pre-symptomatic means that you're just incubating and you will potentially in a couple of days get very, very sick. and you can still get people sick, right? So
Mm-hmm.
the thing about this virus is that you can still potentially pose a threat to others, and others that are seemingly very healthy can pose a threat to you. There's again very few cases of this being passed from mom to the baby vertically.
Mm-hmm.
Few cases. I want to say there's no cases of it being discovered in the breast milk at all.
No, yeah.
So
There's a recent Spanish study that examined like 660 something women, and also like nearly close to zero passing through like even like contact with the baby.
I think that the risk is if a woman is COVID positive and breastfeeding is not that they will pass it through their milk. In fact, we still encourage women to breastfeed because
just through taking care of the baby and just being in contact with the baby.
If you're COVID positive, and we've had perfectly healthy women come in, and just because we test everybody, we find out that they're positive, and it's at the beginning it was a little bit shocking, but now it's kind of just what happens, and very few of them actually show any symptoms at all. They're perfectly kind of healthy. So, we used to take more precaution. Now we encourage everybody to stay with their baby. We encourage everybody to breastfeed. We just say wipe down your breasts before, wear a mask when breastfeeding, but we don't recommend not breastfeeding. So again, terrible things to not believe and not do is we have to take your baby away from you. Not true. Absolutely not true. Unless you're on a ventilator and you can't breathe on your own, you should take your baby away from you because of COVID. No one should tell you shouldn't breastfeed your baby because of COVID. Also not true, not supported by evidence.
Cesarean is also not an indication if you have a COVID.
No.
I heard of such instances in the world.
Again, unless you need a ventilator, you can't breathe, there's no reason somebody should put you through invasive surgery to get the baby at all. Not an indication in and of itself to have surgery. Oh my God, that's a whole other, I think, long talk about.
Oh yeah, what cesareans and indications for it.
We should write a book on all the reasons I've heard people have cesareans that are. I feel like I could write a 10-chapter book on that, and it's just mind-boggling. So yes, so common sense things. I mean, what you should do, and I think what we all should do, really, hopefully, if the silver lining of this pandemic is that we all just get better at washing our hands all the time. We all have the basic hygiene down, which we clearly didn't in the past. As humans in general, we were terrible at it. Just good hygiene. If you're sick, don't go anywhere. Don't be like, oh, I just have a mild cold. And no, just stay home, get well. Don't be around people that are sick. Basic things that are common sense things are the things you should follow. Anyone that tells you extreme measures, you need to stay away from people. Nobody can be next to you because of COVID. Nobody should come to the hospital because of COVID. You have to somehow give up your autonomy as a human being because we're in a pandemic. Not true. None of those. If it sounds like it's bullshit, it's probably bullshit, is my take on it.
Okay, tell me, does it sound like bullshit to you, obligation for a woman in labor to wear a mask?
So let me tell you, in labor, the risk, and especially in the second stage of labor, the risk of transmitting a virus is much higher because you're huffing and you're puffing and you're aerosolizing the virus, right? So we know now when you aerosolize the virus, it can infect for much more than just a meter away. It stays in the air. It's just constantly kind of spewing at you, and this is proven by studies. So what we say to women is we offer a test, a COVID test. Some women decline the COVID test. If they decline the COVID test, we respectfully ask them to wear their mask because that protects us as healthcare providers.
During the second stage
they're huffing and puffing. I have not seen anybody insist on somebody wearing a mask during the pushing stage because, again, we know, this is when humanity has to come in. Like the part of you that this is it's unrealistic. It depends. If you have an epidural and you're totally like doing guided pushing and you're not thrashing all over the place, that's a whole different story. You really have to have an individualized approach. If you're symptomatic in any way, I think it's totally reasonable to ask a woman to put on a mask because safer than exposing, a whole department and a whole labor and delivery unit to whatever you potentially have, especially if you refuse to take a test that can rule you out potentially. So again, I think it's an individualized approach. Do we ever make anybody do anything? No. Again, we're not in the business of forcing anybody to do anything. And I think that you it's a conversation that you have with a woman that I start having from the minute I admit them. This is why we ask you to take this test. It's because we want to protect you. We also want to protect ourselves, right? We have families. We're going back to elderly people in our family too. We have to have a sustainable approach. If we start going down like flies, it's not going to be good for anybody.
That's true. Yeah. No, thank you for clarifying this moment with the masks, because my initial response when I heard of this limitation implemented here, well, in the peak of the pandemic here, obviously my approach was like, are you kidding me? Like, how are you supposed to breathe when you're in labor? But that makes really good sense. And when it does make sense, when you really take a moment and explain it and break it down for me, even though I'm a birth worker and even though I know how birth goes, but in my mind, how it was voiced for women, like wear a mask in the birthing room. But we all know that labor is a long process most of the time, and we really need to break it down for women who are not familiar with the birth process, and to the staff as well, like as of guidelines that, in the first stage, maybe it's really inhumane to ask her to wear a mask preventatively, or maybe break it down for her that, if you could you put on a mask when a staff member comes in? Yeah. To put a CGG monitor, and then feel free to take it off. But the problem is that nobody's breaking it down. Nobody's like guiding the woman through these things.
They don't talk with you, they talk down to you. And that's the problem. But when you talk down to somebody, you're not going to have cooperation with that person. But when you talk with the person and you explain that we're actually in this like really boat, like tumultuous seas together, we're on this boat together. I am protecting myself as much as I would like to protect you. I feel for healthcare providers. I am a healthcare provider. I know what it's like to wear a mask for 12 hours or plus. And not just a mask like this. I mean, one that's fitted. I mean, I have irritation on my skin.
I saw your photo when you posted it, like after 2 hours, I think you said, like you took it off and you had these traces. Jesus.
I just work today. That's why it doesn't look like this. But usually there's irritation all over your face and you're breaking out from the mask being on. So these are real things we're all dealing with. But when you explain that to a woman and you say, look, we're doing this as much for you as we are for ourselves. We have families we have to go back to and protect. I don't want to expose my family to whatever I may get at work. And I'm here every day. So I'm exposed every time I'm here, So if I don't take these precautions, then I'm going to get sick and I'm going to get a lot of other people sick. So we have to protect each other. I understand it's uncomfortable. If you come to a point where you're like, I absolutely cannot breathe, obviously take down the mask, take a few deep breaths, relax. Whenever you can, please put the mask back on. Who, after such an explanation, is going to be like, no, I absolutely don't want to put a mask on?
Exactly.
It's really just about being able to talk with people and not talk down to them. Because when you talk down to people, you're just looking for a fight, and you're eventually going to force them to do what you want, but you're not. Well, not.
Or you're getting a woman who is shutting down and freezing up and obeying you, and we all know how that affects the outcomes of birth and her experience of birth, being like in this paralyzed and quiet mode, and
I mean, it's unnecessary too. It's really just posturing, and it's just expression of your own need to control the situation, when you can get much more accomplished when you just have a very humane approach. So it's just a switch. It's a values thing. It's a
and it's also treating pregnant and laboring women as intellectual beings as well, which is frequently what they're denied of, that they don't need to be explained anything because they don't understand what's going on.
Women in general are like not treated with the same regard as we treat men in general, and then pregnant women are even more disregarded. It's like it's very much
a whole different conversation,
cultural.
Which we I hope we will have, because I really loved it. I so enjoyed talking to you. Thank you so much. I really hope that this is going to go out on air, not on air, but like on YouTube, and we're going to get some views and start a conversation. I mean, I really want to join the global conversation about it, because this is so huge for all of us.
Yeah.
Yeah.
Yeah, absolutely. Thank you for having me.
Yeah. I hope to see
I'll
you
see you.
soon and
Yes.
be able to hug you here in
Yes, I
Georgia.
hope so too. I hope so too. I'm due to arrive at the end of August, and after 2 weeks strict quarantine, I'll be ready to
Oh, this is
get
what you're going to go through quarantine. Oh
to
my
do it.
God. Ugh.
Which will be, yeah, not fun, but necessary. And then afterwards,
We're
I'll
gonna
be,
bring you sweets and candies and
yeah,
everything
I'm gonna
tasty
share
that you
my
like. We're gonna throw it to you in the window.
from my window.
Yeah.
That's nice.
Okay.
All right. Well, nice to talk to you. I'll see you soon.
Yeah. Bye.
Bye.